Thank you very much. You probably feel that I picked the wrong virus to get excited about at the moment. But in fact, I'd hope to, in the course of this talk, to convince you that actually if you're going to the Olympics in Rio, you ought to be much more worried about catching chikungunya than Zika as long as you're not pregnant, because I think this is a much more unpleasant infection, but with very similar characteristics in epidemiology. So I'm going to start with a bit of a historical perspective, going back to some of the very early papers describing this infection, which just happened to be published in the Transactions of the Royal Society for Tropical Medicine, as were the original descriptions of Zika virus. So the original outbreak was on a plateau in Tanzania, and it was described by a couple of investigators, one a clinician working with a missionary organization, and the other an epidemiologist and then subsequently virologists from the Vaccine Research Institute in Entebbe. And the locals gave it the word, so it comes from a language called Kimakonde, and that means that which is bent up or is contorted. It's a very undistinguished virus. It's actually an alpha virus, so Zika, dengue, and the others that you hear about are flaviviruses. This is an alpha virus, and it's quite similar to other viruses that have a similar syndrome of fever, rash, and joint problems. And these include the very colourfully named Onyong-Nyong, Sindbis, and Ross River viruses. And there are three major lineages, and I'll show you a bit more about those later. So this is this historical paper from 1952, or published in 1955. And what I find so fascinating about these very early papers is just how much detail they put in, which would now be all removed with by editorial cutting. So there really is. It's lovely to read the descriptions, and all those of you who are members of the RSTMH can access these ancient papers online. So you can see that the epidemic was thought initially to be dengue because dengue is around in that area or had been around in nearby areas. It was the joint pains that was so significant and that led to this name. And interestingly, they also refer to some features which are very evident now in the current epidemic in the Americas, that it's very rapidly spread, that it has a very high hit rate, and in these villages it was 60 to 80% of the population became infected, and often went by household, so in particular huts, everybody in the household was infected. This is the epidemiology paper from William Lumsden, and he's speculating here about why it happened in this particular place. And what seemed to happen was that the farmers from the plateau went down to the lowlands during the rainy season because that was where they did most of their farming. And interestingly, the adult males locally from the lowlands didn't get infected, whereas the ones who came down from the plateau and presumably hadn't been exposed before were the ones where this epidemic really took off. And again, that has resonances with what we're seeing now in the current epidemic. So it was thought that this was a particularly susceptible population, but that the rural population on the in the lowlands adjacent to the forest were perhaps more regularly exposed. And they made a big effort to collect all kinds of insects from the houses and found the virus particularly in the Aedes aegypti mosquito, and thought this was probably the vector of the disease. The virus was finally isolated, and we heard beautiful descriptions of modern next-generation sequencing in the previous session, and I'd just like to highlight that the items used in this piece of research was a small pressure cooker, a primer stove, and a hand centrifuge. And he does actually point out a little bit later that some of the Pyrex tubes were labelled with elastoplast so that they could number them according to the mosquitoes they isolated them from. And they found the virus in blood and in the mosquitoes, and they injected it into mice and found that the mortality was very high. And this helped them distinguish it from dengue, which is difficult to infect mice with and doesn't usually cause them any illness. And when they looked at antibodies from people who had had the infection, they showed that it was distinct from antibodies that recognized dengue virus, but seemed to show some cross-reactivity against what we now know to be a related alpha virus, the Semliki forest virus. So what is now understood about chikungunya is that the panel on the left shows what has been probably happening for a long time, that the virus is in animals, primates, small rodents, sometimes birds, and transmitted round in a cycle in the forests, and then occasionally spills out into humans. But that in circumstances where humans are densely packed together, and because viremia is very high in the acute stages of the infection, human-to-human spread can occur, and this infection can become a major epidemic. We know that now that it's transmitted by 2 mosquitoes of the Aedes species, both Aegypti and Albopictus, and possibly also some Culex species, I think most of the other things on that slide I've said. So what next generation sequencing has provided, or I think originally more in the sort of conventional Sanger sequencing, is that there are 3 distinct lineages of the viruses. There's one that we don't see very often, confined to West Africa down here, the East and Central and Southern African lineage, which I'll talk about shortly, and then the Asian lineage, which is a more recent one. So it looks to be an African virus that spread to Asia probably within the last century. And what's surprising really is that this virus has taken off almost entirely within the last 2 decades. And the outbreak first really surfaced on the Kenyan coast and in big cities, Mombasa in particular, the island of Lamu, and then somehow made its way across to the other islands of the Indian Ocean. And I first personally started following the literature on chikungunya because it seemed to coincide so beautifully with the distribution of coral, and being at the time an enthusiastic scuba diver, it seemed to me that making a career in chikungunya could be a very nice way of going to some very attractive places. However, I failed to convince funders of this and have stayed mostly working on HIV and just thinking about chikungunya in my spare time. And part of the reason that we know so much about it is that La Réunion is a French island. It has this status of being part of France, so it has a modern healthcare system, even though it's in the middle of the Indian Ocean, close to the African coast. And so the ascertainment of chikungunya in La Réunion was very complete, and it's thought that around 1/3 of the whole population of the island was affected over about a year. Then the virus moved its way around the Indian Ocean, through the Maldives, Sri Lanka, some very nice places, all with good coral, then going up around the coast of India and into Southeast Asia. Just in India, in a year, it's thought that 1.3 million people were infected. And then throughout this Indian Ocean epidemic, it finally made its way across to the Polynesian islands, and probably about 2 million people were infected overall. And that was with the East Central and Southern African strain. So when a few cases were reported in the Caribbean, 2.5 years ago, it was assumed that it would be the same lineage. But in fact, it turned out to be an Asian strain, and exactly how it got to the Caribbean is not completely clear. And within a year, huge numbers of cases had been reported, and it spread outwards from the Caribbean and through into the rest of the Americas. And one of the things that's interesting about the spread of this virus is that certainly in the Indian Ocean outbreak, the virus adapted to be more effectively spread by Aedes albopictus. And I'll show some pictures later of how that mosquito is more widely distributed and can take the virus much further than Aegypti could. And that reduces the infectious dose for a mosquito by about 100-fold for that particular species. The outbreak strain in the Americas so far lacks that mutation, so it can be transmitted by Albopictus, although usually isn't. So this just gives you some idea of the scale of the epidemic. So whereas to begin with, there were small outbreaks close to forest areas in Africa, and then there was this movement around the Indian Ocean, going into Southeast Asia, and then now in the central part of Central America and the Caribbean, and then more recently in South America. So, and particularly in Brazil, although many of these South American countries are infected. So it really has become a worldwide epidemic. These are just to highlight some of the Caribbean countries that were affected in the year from 2013 when it was at its height. And now in America, in the Americas, it's particularly prevalent in those countries coloured in red. And you'll see in the countries in blue are where there have been imported cases. A lot of Americans go on holiday to a lot of the places in red and then come back with chikungunya. And as I was taught by David Worrell when I was his registrar, a disease becomes global when it affects Americans. So this is, we can now say, is a genuinely global epidemic. And probably nearly 2 million people have been infected in the Americas outbreak just in the last couple of years. So something on a really massive scale. And in the UK, most of the recent cases, this is just up to 2014, are related to the Caribbean outbreak. And I'm sure many of us who are involved with seeing returning travellers will have seen potential cases. The reason this, as the original reports describe, it can easily be confused with dengue because many of the initial presenting features are quite similar and the epidemiology is similar too. One of the things that's interesting is that it tends to have a very high symptomatic rate of symptomatic infection, so that you're much more likely to present with symptoms and to carry it than you would be with dengue. It's a relatively short incubation period, and what all the early descriptions highlight is just how suddenly and abruptly people become unwell. And the fever is usually very high, 39 degrees or greater, and people complain particularly of a rather itchy, irritating rash and then joint pain. And the joint pain is often symmetrical. It's usually in the wrists, the fingers, and the ankles. Although they may have effusions, it's not necessarily associated with frank arthritis. And I think what has been particularly alarming about it, and particularly well documented in the La Reunion outbreak, is that the complications, particularly in the joints, can carry on for many months and sometimes years. And that was, in the La Reunion outbreak, it was at least a third of the patients still had symptoms at 18 months. Overall, the estimates are about 20%. It doesn't usually kill people, and it doesn't seem to be transmitted through the placenta. Women infected in late pregnancy can transmit it to neonates, and those babies can be quite sick. But it's not associated with the birth defects that have been described with Zika. And there have been occasional fatalities in people who are ill for other reasons. So this is going back to the history. This is a lovely description of the Arthralgia in the first outbreak. The pain was frightening in its severity, completely immobilizing many patients and preventing sleep in the first few days of illness. And even in that setting, the people required morphine to control the pain. So the joint symptoms really are the things that distinguish this from dengue. Most of the other features are very similar. So these are some pictures just to highlight what you might see in a returning traveller. The feet are from a charity worker who came to our ward a few months ago. These feet come from an Indian picture during the Indian outbreak, a lady with more obvious joint swelling in the hands on the bottom left. And here, the patient with more chronic infection and signs of calcification in the tendons and frank arthritis. So the diagnosis really depends on suspicion. It is possible, but only in specialist labs, to make the diagnosis on the basis of a PCR, a specific PCR, looking for the virus in the week or so that people are viremic. Otherwise, it's done using paired sera, and at the same time, you should test for dengue and Zika. And there are case reports of people being infected with 2 or even all 3 of these simultaneously. But the only treatment is supportive treatment with paracetamol and non-steroidals. The problem with the chronic infection is that it can be very debilitating. There have been no trials, but it's been suggested that short courses of steroids may help abate some of the symptoms. But if the arthritis becomes chronic, then this enters into the territory of rheumatologists with the need for methotrexate and other disease-modifying rheumatological drugs. So just to highlight the differences between dengue and chikungunya, because the differential is so it can be difficult. I think the arthralgia and arthritis are key features of chikungunya. Retroorbital pain might be more common in dengue. And odd things like Raynaud's syndrome can be seen in chikungunya as well. Recent reports in CID of nasal necrosis with chikungunya, and that hasn't been described before. That was in patients from Venezuela, hasn't been seen before in other parts of the world. So it's the late complications that seem to be the real sort of really unpleasant feature of this virus. And this again was described in the early descriptions, saying that the joint pains occurred intermittently and in some cases continued for up to 4 months after the original illness. And it was in some districts, remember this was when Tanzania was still a colony, the pain was sufficient to endanger the normal agricultural program. So the people were unable to work because of the pain. So this can either be a recurrence or just a continuation of the symptoms, and it tends to affect several joints and the tendons. It's seen particularly in patients who are older and those who've had pre-existing joint disease such as osteoarthritis. And there's some prediction on the basis of the levels of viral load, although of course in clinical practice we don't usually measure these, and it can be very disabling. And there are several reports now of patients returning to the US and attending rheumatology clinics where the features are thought really to be indistinguishable from seronegative rheumatoid arthritis in the longer term, requiring disease-modifying therapy and monoclonal treatment. It's interesting to see why this virus should have such a negative effect on the joints. And it seems to be that the key feature is that the virus has particular tropism for fibroblasts, and so it will home into muscles, joints, and also skin. It does have tropism for hepatocytes, but abnormal liver function is relatively rare in the condition, and it doesn't usually cause serious hepatitis. So the viremia is mentioned, it can be very high, and the level predicts complications. It initiates a very potent innate immune response, and there's some evidence that the disease has a T-cell mediated component, because if you deplete CD4 T cells from mouse models, the disease is less severe and the joint complications are less. What seems to be happening is that the virus persists in macrophages and probably also in joint tissues, and so a continued immune response against the virus in fibroblasts is thought to be behind the persistent arthritis. There are some biomarkers that are linked with the development of arthritis, but in fact the etiology and the pathogenesis is not particularly well understood. It ought to be possible to make a vaccine against chikungunya. It's relatively the diversity is relatively limited. There's good evidence of protective immunity just from the epidemiological studies that I've mentioned, that people who've had it previously seem to have a good level of protection. And the antibodies are broadly neutralizing and will cover all the major strains of chikungunya. So a vaccine really should be feasible. And 3 different vaccines have been taken into human studies, 2 with viral vectors, one most recently with a measles virus backbone, and a virus-like particle tested at the NIH. But the first 2, although looked quite promising, went into phase 2 trials, but then for reasons that are not entirely clear, interest in them petered out. It looked like it wasn't possible to interest pharma in taking these further. And I think it's not quite clear, and there doesn't seem to me to be a strategy for how these vaccines would be tested, because it seems to be very hard to predict when where the epidemic is going to strike and when to deploy vaccine in an efficacy trial. And the economic arguments don't seem to have been made convincing, at least to pharma, to take any of these through to licensure. So although it ought to be shouldn't be a very difficult thing to make a vaccine, there's no sign that one is on the horizon. And I think probably the key thing that we need to think about with dengue, chikungunya, and Zika is just the difficulty in tackling their vectors. And knowing about these vectors probably helps us to understand how these viruses have spread so extraordinarily far in a relatively short time. And these are viruses, most of you I'm sure will know this, but they have really adapted themselves extraordinarily well to us. Both the Aedes species bite in the day. They are happy to coexist with humans. The Aegypti species comes at you from behind and has a reasonably high range. And they've got sort of tough strategies for surviving. So the eggs can survive long periods of desiccation, and they can breed in really small amounts of water. So just to give you some examples, part of the rise in the Aedes mosquitoes was thought to be discarded tires left around, and import of the mosquitoes, and particularly Albopictus, is thought to have come into the Americas with shipments of old tires. But even on the bottom frame, you can see the hulks of coconuts, and these tiny pools of water are sufficient for a breeding cycle to be undergone. So, and then of course there are all the other containers associated with human habitation, and it's in these sort of water containers outside people's houses that these mosquitoes breed so successfly. So it's very different from the Anopheles life cycle that we think about in terms of malaria. The Aedes aegypti is thought to have come from Africa into the rest of the world predominantly through the slave trade, so several hundred years ago, whereas Albopictus, as mentioned, probably more recently in shipments from Asia. And Aegypti is quite well established in the States. Albopictus is much further up in both California and on the East Coast. So the potential for, and throughout most of southern US, so the potential for spread is into these parts of the world is really very high. So that the Albopictus is also referred to as the Asian tiger mosquito, but you see it's no longer confined to Asia. And as well as the 3 viruses we've been talking about, it can also transmit yellow fever and West Nile virus. And it's on its way back into Europe. It's quite well established in Italy. And chikungunya, there was an outbreak from the Indian Ocean outbreak. A patient came back from India with chikungunya to the area around Ravenna in northern Italy, and at a time when in the summer there were enough mosquitoes to transmit the virus, and it's thought about 200 people became infected in Italy. That outbreak eventually burnt itself out, but it's quite likely, particularly with climate change, that more of the southern Mediterranean will be able to house this mosquito and allow spread of these viruses. So I think I've probably said enough. Really to conclude, this is a virus that used to be very limited in its scope and largely confined to populations living close to forests. But within a very short time, it's spread now to most of the tropics and into the subtropics. And the range is increased through this simple mutation, and it can easily be an infection that we see in southern Europe and southern US, where, of course, the majority of the population will be susceptible. And what we need to think about as physicians is that this is a very debilitating infection in a high number of people, and with complications that can last for many years. So I'm going to stop there and be happy to take any questions.